Good afternoon, dear students. We start another lecture biochemistry, and today we will tell about biochemistry of hormones. We will continue to tell about them because last week we started and we stopped, as I remember, in discussion of growth hormone. That's why let's start today from this position. Growth hormone. Growth hormone, also called somatotropin, is a protein which consists from 121 amino acids. This hormone is produced in a special cells, somatotroph cells, in anterior pituitary. And if we tell about regulation of the synthesis and secretion of growth hormone, it's carried out by the many factors. In main stimulating effect is provided by somatoliberin, or growth hormone releasing factors, which is produced in the hypothalamus under the action of various stimuli like stress, exercises, hypoglycemia, starvation, protein food. And the main inhibitory is of growth hormone production is somatostatin, hypothalamic somatostatin. And as usually we have a number of feedback loop. Likewise, growth hormone effect back to inhibit growth hormone releasing factors secretion, and probably has direct autocrine effect, inhibitory effect on secretion from the somatotroph. High level of insulin-like growth factors, which is produced in the liver, we will tell about these factors a little later. This seem to part in regulation of the growth hormone synthesis and production because it leads to decreased secretion of growth hormone with two ways. One way directly suppressing effect on somatotroph, and one way it's a stimulating release of somatostatin from the hypothalamus. Integration of all these regulatory factors that affect growth hormone synthesis and secretion lead to positive pattern of its release. That's why the concentration of growth of our hormone in our blood is not constant. And the highest level of growth hormone, more than half from the total daily amount, is seen after sleeping. That's why our grandmother quite correctly says that we are growing during sleeping. If we tell about the function of growth hormone, its activity has two types of effect, direct and indirect. The direct effect is a result of growth hormone binding with its own receptor on different target organs. And growth hormone receptors are found in the plasma membrane of different organs, and liver and adipose tissue, and testes, and corpus luteum, and skeletal muscles, cartilage, brain, lung, pancreas, and etc. Such way, like in this picture, you see that growth hormone can stimulate to breakdown of triacylglycerol and in adipose tissue, and suppresses ability to take up and accumulate circulating lipids in the fat, you see, and maybe indirect effect due to a special mediator, insulin-like growth factors 1, which is produced mainly in the liver. One more name of this factor is somatomedin, it's the same, second name of this hormone. This hormone, as I already mainly is produced in the liver in response to growth hormone. And the majority of the growth promoting effect of growth hormone is actually due to this insulin-like factor 1 acting on its target cells. These insulin-like growth factors can act in different manner, an endocrine and paracrine and autocrine mechanism of action. Primary effects of growth hormone are short-lived and insulin-like. In adipose tissue, glucose consumption and lipogenesis increases. And as a result of this is the decrease in the concentration of glucose in the blood. You see, like glucose function, but it's for a short time. In the future, the slower effect appear, opposite to insulin. Lipolysis in adipose tissue increases, the concentration of fatty acid in the blood increases, and in the case of insulin deficiency, the ketogenesis, ketone body production in the blood increases. The energy generated by increases breakdown of fat is used for anabolic processes. Such way, first of all, the anabolism of the protein. You see that at the same time, the use of glucose by muscle cells and other organ cells, yes, decreases. And because we take energy, first of all, from lipids, from fatty acid, due to beta oxidation of fatty acid. Moreover, gluconeogenesis is accelerated in the liver under the action of the growth hormone. And such way, both of these factors lead to hyperglycemia, especially with the lack of insulin. In the main action of growth hormone, the same is regularly, as I tell already, anabolism of the protein, because we associate this protein synthesis with the growth and development of our body. Under the influence of this growth hormone, the transport of amino acid into the cell and protein synthesis inside of the cell of different organs is increased. First of all, of course, in the bones, muscles, cartilage, but in organs the same, like liver and other intestinal organs. Moreover, amount of DNA and RNA and total number of cells the same increase. If we tell about disorder of growth hormone synthesis, it may be lack of this hormone or excess of this hormone. Such disorders can reflect lesion in either or hypothalamus, abnormal regulation, or pituitary problem, abnormal production of growth hormone, or maybe a problem in target cells, problem with receptors on target cells, and such way no reaction on the action of growth hormone. Clinically, deficiency of growth hormone results as a growth retardation or dwarfism. In adults, these men, they are shorter than normal, but they have normal proportional of the body and absolutely normal mentality. If we tell about excess, this result, I forgot to tell that dwarfism caused, if we tell about deficiency of this hormone from early age, in infants, because if suddenly happens the low concentration of this hormone in the adult, it can lead maybe some metabolic processes, but don't influence on our, of course, weight or body mass and size of the body. Because in adult, the basic level of growth hormone is minimum. It's necessary only for control of our metabolism, but not growth. If we tell about excess of this hormone, here the same may be different results. It depends from the age of organism when we see deficiency. And we can see it two distinct disorders. Gigantism, if the result of excessive growth hormone secretion that begins in young children or teenagers age. In other words, we tell about hyper secretion of this hormone prior to the closure of growth center in the long bones. And gigantism, it's an absolutely normal proportion, normal sexual development, normal mentality, only abnormal excess height and weight. This disorder usually resulting from the tumor of somatotrophs. And gigantism is usually treated with radiation, but gland surgery may also be used. Compare normal body and gigantism. Acromegaly results from the excessive secretion of growth hormone in adult after the growth center have closed and the bone grow in bulk and bed. Clinically, the overgrowth of bone and connective tissue leads to a change in appearance that might be described as having coarse picture. See on this picture. In early age, this girl is pretty, but with the age happen changing. And only some of bones are growth. It's the bones of the face, jaw, arms. We don't see on this picture, but legs the same. They get larger. Why? Because the growth center in this bone is not closed, and they can answer on the action of growth hormone and insulin growth factor. Such way we tell about a special symptoms acromegaly. The excessive growth hormone and insulin-like growth factor 1 also lead to metabolic disorders, including glucose intolerance. How to treat this patient? Usually by X-ray to shrink the pituitary, or part of pituitary gland is removed with the surgery operation. Now next hormone, thyroid stimulating hormone, or thyroid 1 more name of this hormone. Thyroid stimulating hormone is secreted from the cells in anterior pituitary called thyrotropes. And this hormone finds receptors in the epithelial cells of the thyroid gland. That's why the main function of this hormone, TSH, is regulation, correctly increases the all phases of T3 and T4 thyroid gland hormones biosynthesis. And it's promote biosynthesis of them in all phases, from the uptake of iodine and proteolysis of thyroglobulin to final maturation of this hormone. Thyroid stimulating hormone is a glycoprotein, and it's a complex glycoproteins, and as I already, you see, it's promote the all phases of T3 and T4 synthesis, from iodinization of them till activation of special enzyme. We took part in the breakdown of this peptide bond, this peptidases, and formation of T3 or T4, like on this picture. We will see this picture one more time later when we tell about the function and biochemistry of directly these hormones of thyroid glands. Now, thyrotropic stimulating hormone, as I tell you already, it's a glycoprotein and consists from two subunits, alpha and beta. Pay attention that alpha subunits are absolutely the same like in another hormone, like in LH, luteinizing hormones, or FSH, follicular stimulating hormone, and in the prima chorionic gonadotropins, placental hormone. Each of these hormones, they have the same, you see, alpha subunits, but unique beta subunits. And the specificity of their binding with a special receptor and specificity of their action depend only from their beta subunits. The most important regulator of TSH secretion is thyroid releasing hormones in the hypothalamus. Thyroid releasing hormone is secreted by the hypothalamic neurons into hypothalamic hypophyseal portal blood. After that, it finds its receptors on the thyrotropes of the pituitary, in the anterior pituitary, and stimulates secretion of thyroid stimulating hormone. And we forgot to tell about one very interesting aspect last week of this steroid-releasing hormone, or thyrolebirin, because it's very interesting. It's one of the shortest peptide in our body. It's a tripeptide. It consists only from 3 amino acids: glutamate, histidine, and proline. If we tell about deficiency of TSH, or maybe mutation of TSH receptors, and some people inherit these mutant TSH receptors. Result of this is hypothyroidism, or decrease of the T3 and T4 synthesis. Sometimes we can see the excess of this hormone production. As a result, it leads to hyperthyroidism, abnormal high concentration of thyroid gland hormones T3 and T4, and this condition called thyrotoxicosis or Graves' disease. Next hormones of anterior pituitary that we will discuss now is ACTH, adrenocorticotropic hormone. It's a single-chain polypeptide, consists of 39 amino acids. Its increased synthesis and release of adrenal steroids by enhancing of the conversion of cholesterol to pregnenolone. It's initiator of this metabolic way of steroid hormone synthesis. It's activator of corresponding enzyme, cytochrome P450. ACTH is secreted from the anterior pituitary in response to corticotropin releasing hormones from the hypothalamus, corticolebirin production. This hormone is secreted in response to many types of stress, which makes sense in view that the stress management function of glucocorticoids. We tell that glucocorticoids, they are hormones of chronic stress. And of course, hormones that took part in regulation of their synthesis from adrenal cortex, they the same took part in our adaptation for chronic stress. Corticotropin-releasing hormones itself is inhibited by the glucocorticoids, making it part of a classical negative feedback loop. Within the pituitary gland, ACTH is produced in the process that also generates several other hormones from one long precursor. Pro-opiomelanocortin is synthesized. It's a large precursor protein. And after that happened, the proteolytical chopped of this long precursor into several fragments. One of these fragments is ACTH, our hormone. But together with ACTH, you see that other hormones are produced. The major attributes of the hormones other than ACTH that are produced together with ACTH has another function. Let's tell about the function, some of them. For example, this from beta-lipotropin produce interesting hormones with weak lipolytic effect. Its major importance is a precursor of beta-endorphin, and beta-endorphin and methenkephalin, these hormones, they are opioid peptides with a pain elevation and euphoric effects. One more hormone is produced together with ACTH. Is a melanocyte-stimulating hormone which can be present in two different types. MSH, which consists from only, it's alpha MSH, which consists of only 13 amino acids, and beta MSH, which consists from 21 amino acids. And MSH, melanocyte stimulating hormone, of course, they are necessary for regulation of pigmentation, production of pigment melanin by melanocytes in the skin. Please remember this, because later we will tell that together with with the more intensive production of ACTH lead to hyperpigmentation. Why? Because together with ACTH, MSH is produced. And when we increase the synthesis of these hormones, of course, together with the effect of positive effect on glucocorticoid synthesis, will be effect on pigmentation of the skin. Next interesting hormone, which produced in the anterior pituitary. Why interesting? Because this hormone has no directly effect on peripheral endocrine gland. This hormone has receptor on target organ like growth hormone and to pattern regulation of many processes. First of all, they tell that this prolactin is a protein, the long protein. It consists from 199 amino acids, and together with other hormones, it's to part, first of all, in the growth and function of mammary gland. What another hormones? For example, estrogens. Estrogens provide a well-studied positive control over production, synthesis, and secretion of prolactin. The increasing blood concentration of estrogen during the late pregnancy appear responsible for the elevating level of the prolactin that are necessary to prepare the mammary gland for lactation at the end of gestation. After childbirth, it helps to start and maintain the making of the breast milk. And you see that it's a function not only for the growth of the breast, but prolactin induces the synthesis of alpha-lactalbumin and casein. It's a main milk proteins. Moreover, prolactin activates the synthesis of phospholipids and triacylglycerol of milk. You see that after, what is the regulation? After childbirth, it helps to start and maintain the making of the breast milk, you see. And first of all, due to production of necessary component of this milk. And this occurs in response to cycling by infant. Stimulation of nipples and mammary gland by occurs during the nurturing leads to prolactin release. This effect appears to be due to a spinal reflex arc that causes release, first of all, of prolactin stimulating hormone from prolactin from the hypothalamus. When cycling stops, prolactin slow and the breast stop making milk. But prolactin has many other effects. Of course, first of all, we tell that prolactin plays this major key role in mammary gland. And stimulating mammary gland development and lactation without any question is the main function of prolactin. From here, and name of this hormone, prolactin. But prolactin is multifunctional hormone. Prolactin receptors are present in the cell of many tissues, and in the liver, and in the kidney, and in adrenal gland, and in testes, ovaries, uterus, and other. For example, prolactin promotes the growth of corpus luteum progesterone production. In men, Prolactin increases the sensitivity of plating cell to luteinizing hormones, and such way took part in regulation of testosterone synthesis. Only at a normal level of prolactin, sperm is able to successfully develop and work correctly. Prolactin affects body weight, participate in development of secondary sexual characteristics, and in the formation of sexual desire. In the kidneys, prolactin reduces the excretion of water, effect of reabsorption of sodium and potassium ions. Prolactin also enhances humoral and cellular immunity. You see how many functions. Now let's tell about disease states. Excessive secretion of prolactin, hyperprolactinemia, is a relative common disorder in the human. This condition has numerous causes, including prolactin secreting tumors or therapy with certain drugs. Common manifestation of hyperprolactinemia in women include amenorrhea, lack of menstrual cycle, and galactorrhea, excessive or spontaneous secretion of milk. Men with hyperprolactinemia typically show hypogonadism with decreased sex drive, decreased sperm production, and impotence. Such men also often, not always, but often show breast enlargement, gynecomastia. It's a pair of hormones, gonadotropins, named from the main function of this hormone because they took part in regulation of function of gonads in male and female organism. And there are two hormones, LH, luteinizing hormones, and FSH, follicular stimulating hormone. Both of them, they are glycoproteins. They are produced in a special cells, in a special cells, under the action of special hormones, gonadotropin releasing factors or gonadoliberins, which are produced in the hypothalamus. Growth hormone, gonadotropin releasing hormone, stimulates secretion of LH and FSH. LH and FSH. LH in turn stimulates gonadal secretion of sex steroid, testosterone, estrogen, and progesterone. And in classical negative feedback loop, sex steroid inhibits secretion of gonadotropin releasing hormone and also appear to have direct negative effect on gonadotropins. So regulation is classical. If we tell about the structure, we already tell that all of them, they have the same alpha subunits and unique beta subunits, and the specificity of their binding with specific receptor and function depend only from their beta subunits. Now let's tell about the function of them. If we tell about luteinizing hormone, this hormone is very important for both of sexes. And first of all, it of course stimulates secretion of the sex steroids from gonads. In female, ovulation of mature follicles on the ovaries is induced by a large burst of the LH secretion known as a pre-ovulatory LH surge. Residual cells within the ovulation follicles proliferate to form corpus luteum, which secrete the steroid hormones progesterone, first of all, and estrogen. LH is required for the continued development of the function of the corpus luteum. If we we tell about the function of this hormone in men, it stimulates the secretion of testosterone, the male sex hormones, by the Leydig cells. Here we tell about follicular stimulating hormones. These hormones take part in gametogenesis, first of all, and spheroidogenesis in the follicular cells and Sertoli cells, development of follicles and synthesis of androgen-binding proteins. Here, control of the gonadotropin secretion. As I tell already, yes, the stimulatory effect of hypothalamic gonadolibirins lead to activation of this hormone secretion of pituitary, which in turn stimulate production of sex hormones in corresponding organs, and this sex hormones has negative feedback regulation on pituitary and hypothalamus. Classical regulation. If we tell about disease station, of course, it leads to abnormal function of gonads, hypogonadism. This condition is typically manifest in the males in the failure in production of the normal number of sperm, first of all. In females, it leads to the same infertility, because it leads to abnormal menstrual cycle formation. It leads to the lack of sex hormones production. But for us, if we tell about, first of all, about the female organism, for us interesting not absolute amount of LH and FSH. For us interesting the ratio of them. Because only when we compare LH and FSH, we can decide is it normal or not for this woman. And of course, for us, interesting the day of their checking, because LH and FSH necessary to check only in the first phase of the menstrual cycle, during first 5 days, because after that happens the normal increasing of their synthesis under the answer of regulation of all this menstrual cycle, and you know that very high level of FSH in male organism show us the absolutely inability of sperm production. It's problem of sperm production, untreatment problem, and if we see very high level of FSH in female organism, it's a signal about already climax of this woman. Now we finished tell about hormones of anterior pituitary. Now let's tell about hormones of posterior pituitary. There are only two hormones, antidiuretic hormones and oxytocin. Pay attention, both of them, they are non-peptide. They consist from 9 amino acids. And they are different one from another only due to 2 amino acids. In ADH here phenylalanine, in oxytocin here isoleucine, you see. In here the same, in ADH here arginine, in oxytocin leucine. All other amino acids are absolutely the same. But if their structure is similar, their function is absolutely different. Let's first of all tell about antidiuretic hormone. One more name of this hormone is vasopressin. You know that about 60% of the mass of the body is the water. And despite wide variation in the amount of water taken in each day, body water constant is very stable, remains very, very stable, incredibly stable. Such precise control of body water and solute concentration is a function of several hormones acting on the bones, kidney and vascular system. But there is no doubt that antidiuretic hormone is a key player in these processes. And here the name of this hormone. EDH is given off by the hypothalamus, and store and finally maturation happen in the pituitary gland. EDH is released when the blood volume falls, when the large amount of salt shown up in the blood, or when pain, stress, or some drugs are present. For example, nicotine and large doses of some drugs cause EDH to be released, but alcohol slows the making of the hormone. What is the effect of this hormone? Main effect, of course, on kidney. EDH, the main effect of EDH is antidiuretic effect. So it's reduce water output with urine. Antidiuretic hormone binds to receptor in the distal or collecting tubules of the kidney and promotes reabsorption of water back into circulation. In the absence of antidiuretic hormone, the kidney tubules are virtually impermeable to water and it flows out as urine. But antidiuretic causes also constriction of arterioles, which lead to increase of arterial pressure. That's why ADH has one more name, vasopressin. Now let's tell a detail about the physiological effect of ADH. When plasma osmolarity is below a central threshold, the osmoreceptors are not activated and antidiuretic hormone secretion is suppressed. But when osmolarity increases above the threshold, the osmoreceptors recognize this and stimulate the neurons to secrete antidiuretic hormone. Secretion of EDH is also stimulated by the decreasing in the blood pressure or volume, condition sensed by the stretch receptors in the heart and large arterioles. Changes in the blood pressure and volume are not near the sensitive stimulation as increased osmolarity, but may patent in a severe condition. For example, loss of 15 or 20 of blood volume by hemorrhage results in the massive secretion of ADH. The most common disease of men and animals related to antidiuretic hormone is diabetes insipidus. This condition can arise from either of two situations: central or hypothalamic diabetes insipidus results from the deficiency in the secretion of ADH from the posterior pituitary. Causes of this disease include head trauma or infection or tumors involving the hypothalamus. Or maybe another variant, nephrogenic diabetes insipidus, occurs when the kidney is unable to respond to ADH. Most commonly, this results from some type of renal disease, but mutation in the ADH receptor gene or in the gene encoding aquaporin 2 have also been demonstrated in affected humans. And the major sign of either type, both type of diabetes insipidus, is excessive urine production. Some human patients produce as much as 16 liters of urine per day. A terrible life. The most common symptoms are thirst, of course, polydipsia, because together with urine we lose many important substances, amino acids, glucose. It's understandable frequency of urination, polyuria, not 2 liters per day, but 16 liters. Nicturia, of course, dry skin, dehydration, and constipation. Next hormone, of posterior pituitary, oxytocin, the same 9 amino acids hormone. And the main function of this hormone, it acts on the smooth muscles, and first of all, smooth muscles of the uterus and mammary glands, causing the uterus constriction during labor and promoting milk release during lactation. But both sexes secrete oxytocin. What is the role of oxytocin in the males? Males synthesize oxytocin in the same region of the hypothalamus as in females, and also within the testes and perhaps over reproductive tissues. Pulses of oxytocin can be detected during ejaculation. Current evidence suggests that oxytocin is involved in sperm evacuation. Moreover, it's necessary for the sperm transport within the not only within the male reproductive system, but maybe within the female already after ejaculation, due to the presence in the sperm fluid this oxytocin hormone. It may also have effect on the some aspect of the male sexual behavior. Maybe we discussed it yet. If we tell about control of oxytocin production, first of all, of course, in the female organism, the most important stimulation for the release of hypothalamic oxytocin is initiated of physical stimulation of the nipples. The act of nursing, of suckling, is related within the few part of seconds, milliseconds, to the brain via a spinal reflex arc. These signals impinge the oxytocin secreting neurons, leading to release of oxytocin. And as a result of the action of oxytocin happen the smooth muscles contraction. If it happened in the uterus, it lead to labor. If it happened in the mammary gland, it lead to milk releasing, excretion of milk during lactation. Number of factors that inhibits oxytocin releasing among the may be different. First of all, acute stress. For example, it's known that oxytocin neurons are repressed by catecholamines. First of all, epinephrine, which are released from the adrenal glands in different type of stress, including fright. Next hormone that we will discuss today is the hormones of the pancreas. And 3 hormones are produced in the pancreas in the 3 types of the pancreas cells. First of all, pancreas is very interesting gland because it has 2 major biochemical functions. Exocrine cells produce digestive enzymes for the digestion into the intestine. And we have the endocrine cells which produce and secrete different peptide hormones which regulate fuel metabolism of our body. These peptide hormones are insulin, glucagon, and somatostatin. They are produced by special cells called the island of Langerhans. Each these cells they produce separate single one type of hormone. Such way alpha cells produce glucagon, beta cells insulin, and delta cells somatostatin. We already discussed this slide, the 2 types of function, exocrine and endocrine. The famous hormones of the pancreas, of course, insulin. Insulin is rather small protein with two polypeptide chains in its active form, alpha chain and beta chain, which join together with two, you see, disulfide bonds. But insulin is synthesized in the pancreatic beta cells as inactive single chain long precursor, pre-proinsulin, and happen two steps of its activation with known for you mechanism limited proteolysis. First of all happens the proteolytic removal of the signal sequence from pre-proinsulin. We remove 23 amino acids and produce 3 disulfide bonds in such way for proinsulin. After that happens, next step of activation with the breakdown of two peptide bond and removal of S-peptide. And from one single chain, we produce two fragments of this chain, alpha and beta, but they join together that already with disulfide bond. Pay attention that S-peptide rather longer can be present in our blood. And now modernly in the laboratory, we check not insulin with its short life, but S-peptide concentration, because it's present rather long time in our blood, and it's more accurate method of the studying of the concentration of insulin. And of course, that regulation of insulin synthesis is directly binds with the level of glucose in the blood. When elevated blood glucose, when level of glucose in the blood is high, this high glucose triggers the insulin secretion, and proinsulin is converted into active insulin with the action of this special peptidases. Yes, and when we can see very high level of glucose in the blood, usually after carbohydrates reach meat. And after that, this already insulin appear in the blood. They decreases the insulin. It decreases the level of this glucose till the normal. How insulin acts? Insulin has two very important mechanisms of action. Three very important mechanisms of action. First of all, insulin increases the glucose uptake into the cell, triggers the movement of glucose transporter to the plasma membrane. Only when insulin binds with its receptor, only after that plasma membrane becomes permeable for glucose. After that, the insulin stimulates the glycolysis, main way of glucose utilization, oxidation of glucose with energy production, because insulin is activator of three main regulatory enzymes of glycolysis: hexokinase, phosphofructokinase, and pyruvate kinase. Moreover, insulin activate glycogen synthase and inactivate glycogen phosphorylase, so that much of the glucose 6-phosphate is channeled into glycogen. When the level of glucose in the blood becomes normal, it leads to the slowing the rate of insulin release from the pancreas. Now you see that there is a closely adjusted feedback relationship between the rate of insulin secretion and the blood glucose concentration. The effect of this regulation is to hold the blood glucose concentration nearly constant in the face of the large fluctuation in the dietary uptake of glucose. On this table, you can see what enzymes are regulated or activated or inactivated under the action of insulin. And you can see that here present not only enzymes of carbohydrate metabolism, but enzymes of fat metabolism. And really, insulin is very important regulator of fat metabolism the same. Insulin also stimulates the storage of excess fuel as a fat. It activates both the oxidation of glucose 6-phosphate to pyruvate via glycolysis and the oxidation of pyruvate to acetyl-CoA. And if acetyl-CoA is not oxidized for energy production, it is used for fatty acid synthesis in the liver. And these fatty acids, after that, they are exported as a triacylglycerol of plasma lipoproteins, very low density lipoproteins which are produced in the liver, and it carries them to the adipose tissue. After that, insulin stimulates triacylglycerol synthesis in adipocytes using this fatty acid from very low density lipoproteins triacylglycerol. And these fatty acids are ultimately derived from the excess glucose. You see, we produce fatty acid from glucose. Such way, in summary effect of insulin, it is favored the conversion of excess blood glucose into two storage forms: glycogen in the liver and muscles and triacylglycerol in adipose tissue. If we tell about deficiency of insulin, it's a diabetes mellitus of the first type. Of course, I have no time now to tell about this detailedly because it must be as minimum one separate lecture, or better two lectures about the diabetes mellitus. But of course, insulin deficiency lead to all this effect. Without insulin, glucose utilization will be decreased, but increased gluconeogenesis, and as a result it lead to increased concentration of glucose in the blood, hyperglycemia. It lead to increasing of osmotic pressure in the urine, and it lead to osmotic diuresis, and as a result dehydration of the organism. Together with this, without insulin, we increase production of ketone bodies. It's additional source of energy because all our organism cells, especially brain, can't take energy from glucose. But high production of ketone bodies lead to ketoacidosis, changing of pH of our organism to acidic direction, and it's very, very dangerous because pH is the stable constant of our organism, and acidosis can lead to coma and death. Glucagon. If we start to tell about insulin, of course after that it is necessary to take about glucagon because it's a main opposite hormone to insulin. Glucagon is a single polypeptide protein which consists from polypeptide chain which consists of 29 amino acid residues. And like insulin, it is derived from longer precursor, pre-proglucagon and proglucagon, by limited proteolytic cleavage, like insulin. But even in the absence of significant physical activity of stress, after some hours, after intake of dietary carbohydrates, blood glucose level fall to below 4.5 millimole per liter, so less than normal, due to the using of this glucose for energy production, especially by brain, but by other tissue the same. Lowered this blood glucose triggers secretion of glucagon, and together with this decreases of insulin release. Glucagon causes an increase in the blood glucose concentration in two ways. Like epinephrine, glucagon stimulate the net breakdown of liver glycogen by activating of glycogen phosphorylase and inactivated of glycogen synthase. Both effects are a result of phosphorylation of regulated enzymes triggered by the second messenger, cyclic AMP. About the mechanism we will tell later. But unlike epinephrine, glucagon, only glucagon, not epinephrine, pay attention, inhibits glucose breakdown by glycolysis in the liver and stimulates glucose synthesis by gluconeogenesis. Both of these effects result from the lowering the level of fructose 2,6-biphosphate. The allosteric inhibitor, you remember, it's an allosteric regulatory molecule which is produced in the liver with only regulatory function, because it's allosteric inhibitor of the gluconeogenic enzyme, main regulatory enzyme, fructose 1,6-biphosphatase, and upside down, it's its activator of phosphofructokinase. Such way, glucagon inhibits gluconeogenesis and it's activator of glycolysis and inhibitor of this fructose 2,6-biphosphate. And insulin decrease production of this allosteric regulator. Such way, due to decreased production of this regulator, glucagon, stimulate gluconeogenesis and inhibit glycolysis. Moreover, glucagon itself has its own direct regulatory inhibitory effect on these three regulatory glycolytic enzymes. But stimulating of liver glycogen breakdown, it's preventing of glucose utilization by glycolysis and promoting of gluconeogenesis with all these effects. Glucagon increase production of glucose in the liver and export of this glucose to the blood, and due to this increase the blood glucose concentration to its normal level. Also, the primary effect of glucagon, of course, it's regulation of carbohydrate metabolism, regulation of glucose level, increasing of glucose level till the normal. Glucagon, the same, has not maybe so strong like epinephrine, but the same has effect on fat metabolism. Glucagon can activate triacylglycerol lipase. Such way it the same binds with cyclic AMP dependent phosphorylation, and this lipase liberates the free fatty acid which are exported to the liver and other tissue as a fuel and can be used for energy production oppositely of glucose, because in such way glucagon change formation of energy from glucose to production of energy from fatty acid. No, except of course the brain, because here without any question the main fuel for the brain is glucose. In such way the net effect of glucagon is I already tell, increasing of glucose in the blood and activation of production of energy from fatty acid. So instead of glucose, we start to take energy from fatty acid, which are produced from triacylglycerol. One more hormone which is produced in the pancreas is somatostatin. It's the same a polypeptide hormone. This hormone inhibits the secretion of insulin and glucagon by the pancreas. And this hormone is produced not only in the pancreas. We know that somatostatin it is an inhibitory effect of the pituitary, which is produced in the hypothalamus. And the result of somatostatin is inhibiting of production of hormones in the pituitary. And somatostatin, the same can be produced in the certain intestinal cells with the same function. If we tell about hormones which are produced in the thyroid glands, and together parathyroid gland, because anatomy they are close one to another. These hormones, they are different. Some of them they are peptide hormones, some of them amines hormones. Such way, if we tell about the thyroid hormones, see here, they are derivative of amino acid tyrosine. There are two types of thyroid hormones. Amines hormones are produced in the thyroid glands. T4 or thyroxine or tetraiodthyronine, because here present 4 iodines in T4, or triiodthyronine, only 3 iodines here present, or T3. Both of them they are active only, and mainly T4 is produced, but T3 is more active, in 4 times actively than T4. Thyroid hormones, they play very important, fundamental physiological processes. They are necessary for the normal cellular differentiation, for the normal growth of the cell, for the normal metabolism of the cell. They have very important role in the and carbohydrates, and lipids, and amino acid metabolism, protein metabolism. It's part in regulation of the heat production in our body. And thyroid hormones, oppositely of another amine hormones, epinephrine and norepinephrine, hormones of the adrenal medulla. Thyroid hormones, they are poor soluble in water. And that's why for their transportation necessary a special carrier protein. And really, almost all of thyroid hormones, more than 99%, they bind to a special carrier, thyroxine binding globulin, glycoproteins which are produced in the liver, and we have additional transport protein for T3 and T4, it's transsteroid, and a little part can be absorbed to albumin. We already tell about the mechanism of its synthesis. In the colloid part of thyroid gland, present in high concentration special glycoproteins, thyroglobulin. And this thyroglobulin, which is produced by the thyroid epithelial cells, and you see secreted into the lumen of the follicles of the thyroid gland. And this thyroglobulin consists from many tyrosines, 134 tyrosines. And after, first of all, under the stimulatory effect of TCH from pituitary, happen the iodinization of these tyrosines in the thyroglobulins. After that, happen the cleavage of peptide bond and removal of tyrosine after iodinization from thyroglobulin, combining of them, and production of special these hormones, or triiodthyronine or tetraiodthyronine. Mechanism of these hormones action. Mechanism like steroid hormones. Because when carrier protein carry these hormones to the target organs, and almost all our cells, they are target cells, they have receptor for these hormones. This carrier protein continue to be in the blood, and only thyroid hormone, they pass membrane, cellular membrane, and appear inside of these target cells, where they bind with specific receptor. And this complex receptor with thyroid hormone, goes to the nucleus, where it binds with a special hormone-sensitive site of DNA and took part in regulation of gene transcription and, as a result, regulation of production of special proteins in these special cells. Such way it took part in regulation of these cells' proliferation, differentiation, and function. If we tell about metabolism of these hormones, of course, you start answering this question from these sentences. That the main function of these hormones is increasing in basal metabolic rate. What it means? Let's tell about these sentences with the biochemical language, from biochemical position. First of all, of course, it took part in regulation of lipid, carbohydrates, and protein metabolism. And one more function, as I already tell, it took part in regulation of our temperature. It's increased body heat production. How? I will explain you now. Let's start from its regulation of metabolism. You see, if we tell about lipid metabolism, increase of thyroid hormone levels stimulate fat mobilization, leading to increased concentration of fatty acid, cholesterol, and triglycerides in the plasma. Triglycerols in the plasma. If we tell about carbohydrate metabolism, thyroid hormone stimulates almost all aspects of carbohydrate metabolism, especially increased gluconeogenesis. If we tell about heat production, here already special effect. If you remember, what is heat? Heat is a variant of the energy, and energy is produced in the inner membrane of mitochondria with respiratory chain. When electrons and protons, first of all, from the beginning, traveling along this respiratory chain, during this happened what? That some energy is released from this electron, and this energy we can use for transportation of the hydrogen from mitochondria matrix into intermembrane space. And concentration of this hydrogen becomes different into hydrogen higher in intermembrane space. It leads to a pair of this electrochemical potential, and this potential leads to activation of special membrane integrating enzyme ATP synthase, which lead to production of ATP. What is the role of thyroid hormones? Thyroid hormones are present in the group of such name uncouplers. What it means? The thyroid hormones that carry a part of protons from intermembrane space again back to the matrix without activation of ATP synthase. Such way, you see electron parts, energy produced, but this energy is not used for ATP synthesis. This energy is released as heat and from temperature of our body. And of course, our temperature directly depends on concentration of these thyroid hormones. When we tell about hyperthyroidism, high concentration of this hormone, the ratio between energy which is released to heat and energy which is used for ATP synthesis is changing, and more energy with the increasing of this hormone concentration, more energy will be used for heat production and less for ATP. From here, main symptoms: increasing of body temperature and weakness. Oppositely, lower concentration of this hormone lead to opposite effect. Now, let's tell about disorder of these hormones. We will tell about hyperthyroidism. Maybe different reasons. It may be very high production of thyroid stimulating hormones in the pituitary, liver disease, thyrotoxicosis, toxic goiter. And one of the main symptoms, it's not only weakness, heat, higher temperature, but very large, you see, golden, increasing of the thyroid glands, enlarging of thyroid glands. But one of the symptoms is a bulging of eyes, exophthalmos. Together with this, we can see another typical symptoms. high production of heat lead to increase of the body temperature, and really the continuously has temperature not normal 36 and 6 but over than 37 and 5. It lead to what? Increase of the sweating, the next enzyme. After that, as I tell already, exophthalmos, maybe stomach and intestinal spasm, fatigue, weight loss, neurosis, small tremors of the hand, and many, you see, different, breathlessness, one of the symptoms, palpitation, yes, heart and bone disorders. So many, double vision, if you will see patient with hyperthyroidism, you always will listen these symptoms. Now, another situation. Usually they lose weight, they are thin, and exophthalmos not immediately, after some time, so of course appear all of these symptoms. If we tell about hypothyroidism, maybe two different variants. It depends from the age of the patient. If we tell about the hypothyroidism in adults, name of the situation, myxedema. What is myxedema? It's the lack of thyroid hormones, deficiency of thyroid hormones, and of course it leads to different clinical state. It's sometimes caused by the surgical removal of all or part of the gland may be reason, or maybe, for example, overdose of anti-thyroid medicine, or maybe atrophy of thyroid glands itself. So maybe different reasons. And the lack of it leads to general depression of the more cellular enzyme system, and oxidative processes results of this hormone deficiency. In such way, we tell about the reducing of the metabolism activity in all our cells. And as a result, it leads to reduce of oxygen consumption, decreases energy production, and lessness body heat. Most symptoms include cold intolerance, fatigue, lethargy, mild weight gain, cold pay, drying, rough hand and feet, reduced attention span with memory impairment, slowed speech, the loss of initiative, they are passive always, swelling in extremities and around the eyes and all face, so myxedema. You see from here. If we tell about male, it's a disorder of the menstrual cycle. It's maybe muscle weakness, joint stiffness, clumsiness, many different symptoms. Agitation, decreasing blood pressure, and sometimes depression till paranoia. Untreated hypothyroidism lead to severe partial swelling, after that may be coma and even death. If we tell about lack of this hormone we already discussed all of this disease. If we tell about the lack of this hormone in early age in the children, name of this already seen syndrome is cretinism. It's condition made by the severe lack of this hormone during the infancy, from early age, and it lead to include such symptoms as dwarfism, plus mental deficiency, mental retardation, superficial features, large tongue, so large that they can't close their mouth, maybe navel hernia, maybe lack of muscles coordination. And the last hormone which is produced in the thyroid glands is calcitonin. Calcitonin is a peptide, and calcitonin has its own single but important function. It's to part in regulation of calcium level in the blood, regulation of calcium metabolism. due to the main effect on calcium metabolism is a suppression effect. It's decrease the level of calcium till the normal if we tell about hypercalcemia. And this high level hypercalcemia, it's a stimulus effect, initiation effect on the production of calcitonin, activation of calcitonin synthesis. How calcitonin decrease the level of calcium in the blood? Due to next effect, you see, suppression of renal tubular reabsorption of calcium. In other words, we remove excess of calcium with urine and inhibits of bone resorption. In such way, we minimize removal of calcium from the blood. Upside down, it took part in activation of calcium mineralization. So, function of calcitonin is absolutely opposite of next hormone function of parad hormone. You know that parad hormone is produced in parathyroid gland, and parathyroid gland anatomy present immediately upside down of thyroid gland. And the function of this endocrine gland is only production of this hormone, parathyroid hormone. And the main function of this hormone, oppositely, this hormone took part in increasing of calcium concentration, calcium or phosphorus concentration in the blood. That's why stimulatory effect of this hormone production is a low level of calcium concentration in the blood. How this hormone acts? Due to next main mechanism. A part of this mechanism we already know, because we know that parad hormone is activator of enzyme in the kidney. Enzyme we took part in activation of vitamin D, formation of the final active form calcitriol from 25-hydroxycholecalciferol. This reaction, final activation of vitamin D and formation of calcitriol happen in the kidney, and one of the activator of this hormone is parad hormone. Another allosteric activator is low level of the phosphorus. And vitamin D already, after its activation, took part in increasing of calcium reabsorption in the kidney, the same directly, and increased absorption of calcium in the intestine from our food. Another function of parad hormone, it took part in bone demineralization. It took part in the removal of calcium from the bone for increasing of calcium concentration in the blood. Because calcium concentration, the same, is very stable constant of our body. Calcium plays a very important role. It's necessary and for muscle contraction, and for nerve impulse, and as the second messenger, and for activation of many enzymes, and for muscle contraction, and so on, and for the formation of nerve impulse, you see. That's why it's necessary to keep this level normally. And you see the two hormones as minimum, calcitonin and parad hormone, together with vitamin C, together with vitamin D, and together with another hormones, sex hormones, for example, they took part in regulation of this level in the blood due to different mechanisms. Due to all this mechanism, until we achieve normalization of calcium level in the blood, it lead to already stop of parad hormone synthesis in parathyroid glands. If we tell about disorders of this hormone, decreases of parad hormone secretion by parathyroid glands, it's manifested as a hypocalcemia, of course, decreasing of the blood concentration. Which finally may lead to muscle spasms. What is the main cause of this situation? Usually it happened traditionally, it happened during the incorrect treatment, incorrect thyroidectomy, removal of thyroid gland, and sometimes together with this gland, parathyroid gland, the same can be removed. Or maybe sometimes idiopathic form, which lead to absence of parathyroidism. Sometimes we see it in some patients, or atrophy of this gland. The same it lead to decreased concentration of calcium, first of all, parat hormone, and after that calcium in the blood. But maybe another situation, hyperactivity, high concentration, high production of parat hormone, which lead to finally to hypercalcemia. It manifests in many different symptoms, which include bone pain and backache, and can lead to fatigue and hematuria and dilute of urine. You see, maybe different symptoms, still the same, changing of the behavior, changing of the can be changing from the CNS symptoms, including depression and paranoia. But one of symptoms, of course, is hypercalcemia. And we already know that hypercalcemia can lead to calcification of different soft organs, a pair of the calcium stones, or in the blood vessels walls, or in the kidneys, or in the brain, or in the liver, or in the heart even, and sometimes can lead to death. And one more hormones that we will discuss before the steroid hormones, it's the hormones of adrenal medulla. It's the same amino hormones. They are produced from amino acid tyrosine, and the common name of them is catecholamines, and we know 4 active catecholamines: DOPA, dopamine, norepinephrine, and epinephrine. I name them according to their synthesis, because we know that they are produced one from another. Oppositely of T3 and T4, which the same are produced from the tyrosine, these hormones, they are water soluble. That's why not need for their transported any special transport protein. And the famous sentences about them, that these hormones, this is hormones of fight or flight. What is the function of these hormones in our body? First of all, these hormones, of course, they have biochemical effect. They took part in regulation of our metabolism. Together with glucagon, epinephrine increases the blood level of glucose. Due to what mechanism? First of all, by stimulation of the glycogen breakdown in the muscles. After that, by inhibition of glycogen synthesis in the muscles. After that, by inhibition of glycolysis in the muscles. Due to decrease activity of all these 3 regulatory enzymes of glycolysis. You see that mainly I tell muscles, because the main target organs for epinephrine is the muscles. After that, it stimulates, of course, the fatty acid mobilization in adipose tissue, because if we can't take energy, if we stop glycolysis and can't take energy from carbohydrate, necessary to give alternative fuel for our body. And this alternative fuel, traditionally, of course, is the fat. And of course, glucagon, it stimulates production of glucagon and inhibits insulin secretion. All this effect lead to increasing of glucose concentration in the blood. Only pay attention that epinephrine, oppositely of glucagon, does not affect or have not effect on gluconeogenesis. And of course, we know that these catecholamines has one more effect. They are not only endocrine hormones, they are the same neurotransmitter, and they have a number of effects like neurotransmitter. They can increase the rhythm of cardio rhythm and many other effects. Now steroid hormones. Steroid hormones, all of steroid hormones, they are derivative of cholesterol. And we have two classes of steroid hormones according to the place of their synthesis. One of them are produced in adrenal cortex. That's why we call them adrenocortical hormones. Another are produced in peripheral endocrine glands, gonads. That's why we call them sex hormones. All these hormones, they are lipid soluble. That's why for their transported necessary transport protein. They are not present in our blood in free fall, and they have mechanism. They have special mechanism of action, and we call this mechanism of steroid hormones. As I already tell you, the precursor of all steroid hormone is cholesterol, and we start all of them synthesis from the conversion of cholesterol into pregnenolone. And a special enzyme which catalyzes this reaction is cytochrome P450, mainly present if we tell about this reaction in the mitochondria. And we know already, we discussed it, that the activator of this enzyme is ACTH, which stimulate production of steroid hormones from cholesterol. So activator of this way is ACTH. Now, let's tell about each hormones especially. And we start from hormones of adrenal cortex, which are produced in adrenal cortex. There are three lobes in adrenal cortex, three distinct zones. Zona glomerulosa, and in this zona mineralocorticoids are produced. After the zona fasciculata, where glucocorticoids are produced, and at last reticularis with androgen synthesis. How we start their synthesis? We know that when animals are under stress, the hypothalamus secretes ACTH, cortisol releasing, first of all, cortisol releasing hormone in hypothalamus, which stimulates the anterior pituitary to release corticotropin or ACTH into the blood, and with this already corticotropin in turn took part in production of hormones from the cholesterol. First of all, the main effect of this hormone is to part in activation of glucocorticoid synthesis. Name of this hormone already tell us about the main function of this hormone, glucocorticoids. It means that this hormone directly took part in regulation of carbohydrate metabolism. And really, first of all, one of the important functions of this hormone is promote gluconeogenesis. Glucocorticoids, it's a family of different hormones, and the strongest of them is cortisol. The level of cortisol in our blood is not constant. It has a special rhythm of its synthesis, and of course its rhythm depends from ACTH releasing, and the highest level of this hormone is early morning and the lowest in the evening. Because later we will see that one more name of this hormone is the hormone of the acute stress. And of course, we must be ready for our life, and our days, it's our chronic stress. And for preparing for this stress, we have very high level of this hormone early morning. After production, this hormone, cortisol, binds with a special carrier protein, trans-14, or corticosteroid binding globulin. It's from alpha fraction. But a little amount of cortisol can bind with albumin. And the present little part, less than 8% of free form, and this in free form, and this free form is our active cortisol. If we tell about regulation, we already tell it's a classic ring. And for the activation of cortisol, we produce from after the integration of different stress information in the hypothalamus, we produce corticosterol releasing hormones, which increase production of corticotropin, which in turn increase production of glucocorticoid in internal cortex, and we have feedback regulation, negative regulation of this hormone releasing. What is the effect of this hormone? As we tell already, first of all, it's increased glucose production due to gluconeogenesis. We know that the gluconeogenesis is the biosynthesis of glucose from non-carbohydrates. And the function of this enzyme, first of all, it's increased production of glucose from amino acids. After that, it promotes the glycogen synthesis due to increased production of the glycogen, due to increased activity of glycogen synthase. This hormone the same has very interesting effect on lipid metabolism because it's promotes together in lipolysis and lipogenesis, but in different tissue, different effect. It took part in activation of lipolysis in extremities of our body and lipogenesis in the central part. So it leads to accumulation of triacylglycerol in the center of our body. If we tell about protein metabolism, it's already, I think, that understandable that it promotes catabolism of the protein and releasing of amino acid from these proteins. For what? For using of these amino acids for glucose synthesis. But this hormone has another very interesting function. First of all, it suppresses the immune system due to the lysis of lymphocytes and decrease the number of leukocytes response. And very widely we use this effect of cortisol in the medicine. You know how widely we use hydrocortisol for treatment for suppressor of immune system, for example, during the when we give donor organ to recipient and necessary to suppress immune system, or another way happen the what? Removal of these donor organs. These hormones the same have anti-inflammatory effect and anti-allergic effect due to inhibits formation of eicosanoids, first of all prostaglandins and leukotrienes and thromboxans. Why? Because this hormone inhibits phospholipase A2 and it's a rate-limited enzyme in eicosanoid synthesis. And this effect in anti-inflammatory and anti-allergic effect, the same very widely we use in the medicine. And we tell that we have steroid anti-inflammatory drugs. And hydrocortisol, it's the base of this therapy. Very interesting syndromes of these hormone disorders. If we tell about the lack of this hormone, name of this syndrome is Addison syndrome. But here may be two variants. It may be primary Addison syndrome when we have a problem with directly in adrenal gland, in adrenal cortex, which may be or partial or complete failure, and it's lead to problem of this hormone synthesis in adrenal gland, and gives very interesting symptoms: hypoglycemia, of course, intolerance to stress, anorexia, and as a result weight loss, weakness, decreased blood pressure, due to increasing of glomerular filtration, plasma, sodium, and increasing filtration of the calcium, it lead to abnormal concentration of sodium and calcium in the blood, and it lead to decreasing of blood pressure because sodium goes away, hyponatremia, and together with sodium water is lost from the body, hyperkalemia, and without this hormone, we can't excrete hydrogen from with the urine normally. It leads to accumulation of the hydrogen in the body, and as a result, we can see acidosis when we tell about Addison disease. And together with this, darkness of the skin. That's why one more name of this disease is a bronze disease. No other symptoms you see that depression really very slowly speaking, sensitive to cold, restlessness, these symptoms. But why bronze disease? Do you remember this is Addison symptoms, bronze disease? And do you remember we tell that together with ACTH, MSH is produced? What is the situation here when we tell about the primary Addison disease? The lack of this hormone, because we can't produce them normally in adrenal glands, lead to stimulating of ACTH synthesis, and it lead to very high concentration of ACTH because in any patient, adrenal cortex can't answer on the action of this hormone and can't produce more glucocorticoids. In such way, it lead to continuously high production of ACTH, and together with each MSH is produced. It lead to activation of pigmentation, formation of melanin in melanocytes. If we tell about opposite effect, oh, I have no time, enough time. It's a Cushing syndrome. Cushing's disease, or in Russian we tell about Itsenko Cushing, because our scientists in Itsenko the same took part in describing of these symptoms. It's already high, very high concentration of this hormone of glucocorticoids, and usually it's due to the adenoma or carcinoma of directly. I don't tell about this. That we tell about the primary, you see, and maybe secondary Addison disease. Secondary, when problem appear already in the pituitary, and it lead to the lack of ACTH. Absence of ACTH lead to problem with glucocorticoid synthesis, and symptoms will be absolutely the same as Addison disease, only without pigmentation. Of what I tell you about this mechanism. Now Cushing syndrome. Cushing syndrome is an excess of glucocorticoids. Usually it's a high production or ACTH or maybe a tumor of adrenal cortex. And as a result, a very high concentration of glucocorticoids. Of course, it leads to what? First of all, high level of glucose, hyperglycemia. That's why one more name of Cushing disease, it's a steroid diabetes. Together with this, it will be alkalosis, because glucocorticoids stimulate releasing of protons and potassium with urine. That's why it leads to alkalosis and hypokalemia. Very high reabsorption, increasing of reabsorption of sodium lead to hypernatremia. If we tell about metabolic effect, you see hyperglycemia because very intensive promoter of the gluconeogenesis. After that, intensive lipogenesis in the central part lead to a pair of central obesity and buffalo hump. Increasing of lipolysis in extremities lead to very thin extremities. Together with this happened the moon phase, round moon phase, due to the edema of the moon. After that, it's abnormal pulpish striae on the skin. It can lead to infection. It can lead to osteoporosis. It leads, usually one of symptoms is a heavy growth of the hair on the face, especially when we tell about, of course, women. It's a main symptom of this disease, Cushing syndrome. And one more very hard symptoms, it's untreated high blood pressure. Due to hypernatremia, it's understandable. Now, next very important hormone which is produced in the adrenal cortex, mineralocorticoids. It's a pity. I almost have no time. That's why I'm very fast to show you only what that you to know and prepare. First of all, of course, you have to know the structure of all steroid hormones. Pay attention. This is cortisol, the base cholesterol. They differ, all these hormones, only due to these radicals. And of course, it's understandable. The name of the famous and active from mineralocorticoids family is aldosterone, because pay attention that here on this place present aldehyde group, aldehyde from here, aldosterone. At home, please to read the function of aldosterone. Of course, it's necessary to tell about renin-angiotensin system. I think that I will have enough time to explain this system later when we will tell about biochemistry of the kidney and about the disorders, of course, and primary aldosteronism, cone disease, and secondary aldosteronism. Pay attention on this disease when you will read this information in your textbook. Necessary, of course, to tell and to read and to tell about adrenal hormones, dihydroepiandrosterone and androstenedione, which are produced in adrenal cortex, because these hormones play a very important role, especially in the female organism. Please to read. After that, of course, sex hormones. I think that you know the main function of these hormones in our body, testosterone. And here pay attention about disorders, maybe testosterone deficiency problem with its synthesis, hypogonadism, or maybe upside down, testicular feminization, very high level of testosterone, but absence of the normal receptor for this testosterone. That's why level of testosterone is normal or even higher than normal. But cells can't recognize this testosterone, and it leads to development of this organism is female genotype, even it has male genotype. You see, name of this is testicular feminization. This is man. You see, XY. But phenotype is like woman, testicular feminization. No progesterone, I have no time already. Absolutely, only pay attention. One more very important function of estrogen is to part of the same in the normal mineralization of the bone. That's why postmenopause time, when we can see deficiency of the estrogen, one of the big problem in this situation is osteoporosis. And of course, it's so pity that I have no time to explain you mechanism of their action, mechanism of second messenger for the peptide hormones. And please pay attention on the insulin action, because insulin has its own function. It's the same took part in phosphorylation, but not due to second messenger. Insulin has its own very interesting, active, absolutely unique receptor. Please read about this the same. And the function of mechanism of steroid hormone action we already discussed last week. When we tell about the mechanism of vitamin A and D, they have the same function. It's a regulation of gene expression. It's fantastic to give you so many information for so short time. That's why some of information you have to read yourself. That's all for today. Goodbye. I see you after 3 weeks when we will tell about biochemistry of the kidney. But next lecture is very, very important for you. Next lecture will give you Professor Efetov. Please come and listen. Goodbye.